Hello, I'm Panteleimon Ekkekakis from Iowa State University, and I have to follow up this excellent presentation by Dr. Trivedi by addressing the other side, the dark side. So Dr. Trivedi said that there is good evidence. It is now time to recommend physical activity for the treatment of depression, but he also stated that the actual adoption or implementation of physical activity has remained low. And I want to highlight some of the possible reasons why we are in that state today. So exercise is medicine is making progress. This is the American Psychiatric Association guidelines from 2010 for the treatment of adult depression. With progress, there are also some unintended consequences, unfortunately. For every action, there is an equal and opposite reaction, and in science, that equal and opposite reaction is called bias. Bias is everything that takes us away from the truth. So let me set the stage for just a second. In the area of the treatment of depression, there has been I can call it cataclysmic event. In 2008, we had the meta-analysis by Irving Kirsch, which stated something that I think a lot of us kind of knew or suspected, and that was that the difference in effectiveness between antidepressants and placebo really becomes significant only for those patients with severe initial baseline levels of depression. Now, the implications of this, as you can imagine, are quite significant. And they have led to a stepped care way of thinking for the treatment of depression, which several healthcare systems and countries, I guess, or national healthcare systems are now considering. So the initial approach was that antidepressants can be considered or should be considered as appropriate treatment for the entire range of severity. And in the stepped care approach, you see a much more diversified picture where you have several so-called low-intensity treatments for those patients with subthreshold mild and moderate levels of depression. Then you have cognitive behavioral therapy and other forms of psychotherapy for those with mild and moderate and occasionally severe levels. And you withhold use of antidepressants only for those patients with moderate and severe levels. So you can, of course, imagine the economic implications of this and the market implications of this change to a stepped care approach. So Kirsch has been quite vocal. There was a 60 Minutes interview. There was a book. So there was a lot of notoriety, a lot of noise around Hirsch's analysis. Now, in particular, with respect to exercise, there's an interesting section that I wanted to read to you. So according to Hirsch, the effects of exercise, the antidepressants effects of exercise are placebo. Of course, you and I may have different views on that, but in his view, there's a good chance that the exercise effect is a placebo. But nevertheless, look at what he says. Even if it is a placebo effect, consider the differences between exercise and antidepressants in side effects. Side effects of antidepressants include sexual dysfunction, nausea, vomiting, insomnia, drowsiness, seizures, diarrhea, and headaches. Side effects of physical exercise include enhanced libido, better sleep, decreased body fat, improved muscle tone, greater life expectancy, increased strength and endurance, and improved cholesterol levels. So if both antidepressants and exercise work by means of the placebo effect, which placebo would you prefer? Which I think is a interesting question to pose. So needless to say, Hirsch's analysis has been vigorously and aggressively opposed and criticized, and part of that criticism has included attacks against exercise. So these are just two from a whole series of extensively self-plagiarized, if I may say, papers, which basically repeat the same thing over and over again. And when it comes to exercise, this is what the statement is. Data on the efficacy of exercise and other alternative therapies are either negative or do not exist at all. So everything that Dr. Trivedi just showed you just doesn't exist. It's just a figment of our imagination. So Dr. Trivedi also mentioned that when you ask the patient, sometimes you get very positive, if not enthusiastic, endorsement of exercise. So this is a survey, the largest that we have. It was done in Australia, more than 2,500 patients that actually had been diagnosed with clinical depression. They evaluated a total of 31 different interventions, formal and informal interventions for the treatment of depression, and only those treatments that had been tried by at least 100 people were included in this analysis. So these are the results for effectiveness. Exercise was rated highest at the same level as the most perceived effective antidepressant. And interestingly, also exercise had been tried by more than 2,000 people. So these are pretty stable statistics. But then they also computed an index of effectiveness minus perceived burden, which primarily consists of undesirable side effects. And when you include that, then exercise is rated as the highest, the effectiveness to burden ratio. Now, I want to show you a couple of cases from the UK. For specific reasons, most of the issues that are troubling us, or me anyway, these days come from the UK, and I can explain why that's the case. So one is the TREAD trial, a different TREAD trial than the one that Dr. Trivedi mentioned. So there was a TREAD UK as opposed to the TREAD US trial, and also a series of meta-analyses, and I call them the Bristol meta-analysis for lack of a better word, because most of them include researchers, or all of them include researchers from Bristol University. So in the UK, there is, like in the US, there is exercise and physical activity are included as part of the national guidelines for the treatment of depression. So on the left, you see the guidelines from England, and on the right, the guidelines from Scotland, but the essence, when it comes to exercise, the message, the statement is essentially the same. So I'm going to concentrate on the ones from England. And this is the statement. So if you have a patient with subthreshold, mild, or moderate depressive symptoms, then physical activity should be presented to the patient as one of several options. Other options include low-intensity psychological treatments, such as self-help, CBT-based books, or computerized CBT-based treatments. But a structured group physical activity program should also be presented according to the guidelines. Now, the UK healthcare system, the NHS, is quite different, so I don't know how many of you are familiar with some of the peculiarities of that system, but as you can tell already, the treatment follows an algorithmic approach. So as a general practitioner, you have to screen for depression, and then based on the scores on the screening questionnaire, you sort of triage patients and give them the different treatment options according to the guidelines. And if you follow the guidelines, you actually get incentives. And if you demonstrate, and there's a whole system of demonstrating whether you adhere to the guidelines, you get some incentives back. In addition to that, because there are national healthcare guidelines, GPs are supposed to follow those. They're considered national healthcare policy. So one possibility is, which has not been tried yet, but it's out there in the horizon, if a GP has not followed the nationally recommended guidelines, there's the possibility that they may be sued, and under British law, that lawsuit actually has a good possibility of going through. So this is a very interesting paper that was published in the British Journal of Sports Medicine in 2012. On this basis, if a doctor managing a patient with any of these diseases has not followed these guidelines and advised or signposted appropriately on physical activity, then it is possible that medical negligence has ensued and the practitioner could be sued for malpractice. So it's a quite different environment from the US environment, for sure. Now, Do physicians actually follow the guidelines? The answer, as Dr. Trivedi already said, is definitely not. So this is a survey of GPs regarding patients with mild or moderate depression. Exercise, according to the GPs, is offered as the first choice in 4% of the cases, antidepressants in 45% of the cases. If you ask the patients, as you might expect, things are even worse. So patients with diagnosed depression remember exercise being brought up in the conversation 1% of the time, and antidepressants were prescribed 46% of the time. But when you ask the patients, if you had a choice between antidepressants and exercise, only 4% say that they would choose the antidepressants. And this brings us to the TREAD trial. So I don't know how many of you are aware of this. This made the news a couple of years ago, and I think it's a historically unprecedented and remarkable case. And I think exercise is medicine has a lot to study and a lot to learn from this case. So the conclusion from this trial, published in the British Medical Journal, was no evidence that participants offered the physical activity intervention reported improvement in mood. So I don't know if we have audio. I will try to make this work.
The results of a study published in the British Medical Journal may surprise you. It's generally been supposed that one way of easing depression is to get some exercise, but in a systematic clinical trial on 361 patients, no evidence was found for that. Exercise added nothing to standard therapy in improving outcomes. Professor John Campbell was involved in the research and is Professor of General Practice at Panteleimon Ekkekakis. Were you surprised by the results of this?
Well, we were, I think, to some extent surprised that it was a carefully designed study, and it's an important study and one of the largest studies that's been conducted in the world. And I think we did anticipate that exercise might have more of an effect than we actually saw for treating this very vulnerable group of patients.
Was it really absolutely zero?
Yes, it was. It was an important study because it gave such a definite result. It was quite clearly no difference between the people who increased their activity and their exercise compared with the people who hadn't actually had that opportunity.
It leaves an interesting question as to where the idea that exercise might improve your mental well-being, where that idea came from.
Well, I think that is probably understandable. Many of the studies that have been done internationally previously are very much smaller than the study that we conducted with our colleagues in Bristol. And this was a large study which had sufficient what we call statistical power to look at important differences that might result from the intervention that we were offering.
I mean, it certainly, you might have expected, I suppose, there to be some beneficial effect on the mind. If you run long distances, you can get a kind of elation. I don't know whether the body produces serotonin or something like that, but it does seem to have an effect. So it is surprising that it seems to have none on people who are really depressed.
Well, that's right, and we all do experience that, and I think we certainly acknowledge that exercise, the message of this study, of course, is not that exercise isn't good for you. We know that exercise is very good for you, but it's not good for treating people with what was actually quite severe depression. And we don't think it adds anything. But that buzz that people get from exercise, and we all get from sort of moderate intensity of exercise, is certainly acknowledged and is absolute. But it's not sustained, and it's not appropriate for treating people with depression.
So it's not advice not to exercise. But what would remain then the clinically proven therapies, best evidence-based, I suppose, therapies for depression?
And that's exactly the right observation, Evan, because we are looking for evidence-based treatments. And, GPs every day in their surgeries are dealing with people who are depressed, and there are very good treatments available for depression. Drugs, obviously, and there's a wide range of drugs that people can use if their doctor judges that that's appropriate. But also the talking therapies are probably underestimated in their value. Really very important, the counselling and things like cognitive behavioural therapy, which is also very important. So there are good treatments, and sadly it appears that exercise as a treatment in its own right is probably not substantiated.
So even though this destroyed my timing, I thought it was important to include. So just to recap, there was absolutely no effect, no benefit. There are good treatments out there, and exercise is just not one of them. Is that the gist of what you got from this? Okay. So there was a press release, UK study into whether physical activity aids depression finds no additional benefit. The British media, exercise no help for depression, exercise doesn't help depression. The British Medical Journal sent out an email to all of its registered subscribers, tens of thousands, and the message read, exercise is good for depression. Right? Wrong, according to this study. So we have no evidence to support advising depressed patients to exercise, and advising exercise may increase a depressed person's sense of failure and guilt if they cannot follow the advice, which goes against the Hippocratic Oath. No physician, of course, wants to do harm. There were editorials that repeated the same thing. Advice and support to be physically active does not seem to offer benefits and should not be given a standard, and in fact you may do harm. Clinicians should not advise people with depression that physical activity will increase their chances. Perhaps exercise should not be seen as a treatment for depression. Exercise no help for depression. Exercise does not help depressed patients. This is from a nursing newsletter. Had an interesting quote. You know you're going to get patients saying, this is rubbish. I'm not going to do it, because they have heard the story too. In scientific publications, it's the exact same message. A study showed no benefit. Exercise is not a panacea. The patients that actually participated in the trial received a letter that said that exercise unfortunately didn't work, but it was still good work because it ruled out treatments that do not work, and that saves wasted effort and points researcher towards areas that may have greater benefits. So what did the study do? The intention was to evaluate whether physical activity can be effective treatment for depression in primary care. So that makes people think, and I think that's how most people read the study, that there was an independent variable called exercise or physical activity. There was a dependent variable called depression. That's not what happened. The study did not manipulate physical activity. It manipulated advice to be physically active, which is a different design altogether. It cannot address the question of whether physical activity benefits depression. In this particular case, if you don't see a difference in the dependent variable, that failure could be attributed to the mediator, namely physical activity, but it could also be attributed to the independent variable, namely the advice. In addition to that, the design, for those of you who are familiar with the paper, it was what we call the A plus B versus B design, in which both arms of the trial receive usual care, but then one arm of the trial receives an additional component. Now, one thing that should be apparent is that, again, this type of design cannot answer the question whether physical activity can be an effective treatment for depression, for the simple reason that the trial has no physical activity arm. And another point of view is that this is actually an intensely biased design, because there's additional contact time here, right? So when there's additional contact time in a particular arm, that usually biases the trial in favor of that arm, except when the two arms don't actually differ. And that's what I wanted to show. So what is usual care in the UK? In the UK, usual care for depression, I think I already mentioned it, antidepressants, and 60% of the patients were on antidepressants, some type of psychological therapy, 20% received that. Then there are also exercise on prescription schemes, a nationwide network of exercise facilities that are led by certified exercise experts, and then secondary mental health services. Now, what percentage of patients receive this or this, we do not know. What we do know is something quite interesting. The patients knew that they were in a physical activity trial. The benefits of physical activity had been explained to them. So when they found out that they were not randomized to the physical activity arm, they went back to their physician and said, I want the physical activity. You told me that this was a physical activity trial, so I want to be on that. And the physicians then gave them more referrals to exercise on prescription schemes. That's the patients in usual care. So what ended up happening was that both arms actually received pretty substantial exercise. And if you look at the differences between rates of physical activity participation between the two arms, they differed minimally. Now,
we have 5 minutes.
Yes. So it's interesting to see how these results were analyzed. So with clinical trials, as you know, there's a protocol, and you have to state in advance how you are going to analyze your results so that you cannot change the rules of the game to suit your agenda. So physical activity data were supposed to be analyzed in two ways. One is an intergroup comparison at 4 months, and the other was a group by time analysis for the duration of the trial and the follow-up. And these are the results. Non-significant for the first analysis, non-significant for the second analysis. But in the abstract, the author stated that there was a difference in physical activity between the trials, and you only find out in the results that that only came about after violating the analysis protocol and collapsing the physical activity data from all the different follow-up periods. That was the only analysis that produced significant difference between the arms. What is remarkable is that then the authors went back after the results had been published, and they changed the hypothesis of the trial in the registry. So they added the word, instead of does physical activity improve depression, they said does facilitated physical activity improve depression. So we did not really acknowledge that they did not really manipulate physical activity. That did not differ. What they manipulated was the provision or not provision of the advice. So then, when they were criticized, they came back and said, but wait a minute, we did not evaluate exercise or even physical activity, but the effect of our intervention on depression. And if you're confused, then please read our paper. Now, unfortunately, this reply, you have to be a BMJ subscriber to get it, whereas the paper is publicly available. Anybody can get it. Now, I'm going to close with this, just to demonstrate how malleable and plastic evidence really is. So what I will show you is a comparison between the TREAD trial and other trials that were run by the same investigators at the same time in the same areas of the UK, using the exact same design and the exact same measures and the same time. So these are 3 different trials. All of them tested different types of CBT, cognitive behavioral therapy. And what I'm showing you here is the usual care groups from the other trials. This is the usual care group from the TREAD trial, and this is the intervention group from the TREAD trial. So you can see how much more effective the usual care group from TREAD was than the usual care group from all the other trials. On the right, I'm showing you the intervention arms of the other trials. So these are the CBT groups compared to the usual care group from TREAD and the intervention from TREAD. So I'm going to concentrate on the right-hand side and show you that by the end, by the final follow-up, the usual care group from TREAD outperformed the intervention arms of all the CBT trials, and the intervention group from TREAD was actually even better than that. So these are BDI score changes from baseline. These are remission rates, which were defined as BDI-2 scores of less than 10. And you can see again how the usual care outperforms the intervention from the other trials. And these are changes in antidepressant use from baseline. So that was actually an objective indicator. People who could be taken off antidepressants, the usual care group from TREAD outperformed all the CBT groups from other trials that were going on at the same time. So why was usual care from TREAD so effective? Number one, patients discussed physical activity with their physicians, as the guidelines instruct them to do. The patients completed physical activity logs, as the guidelines suggest. And the patients received referrals to exercise on prescription schemes, as the guidelines suggest. So the reason why this usual care group was so unusually effective, more effective than any intervention, was that in this particular trial, the GPs actually followed the guidelines. So I'm going to leave it at that. We just scratched the surface here, as you can imagine. There's a lot more, and I'm going to open it up to questions for both myself and Dr. Trivedi. Thank you.